Good afternoon. Welcome to Research Grand Rounds, and I'm happy to introduce the speaker for today, as Dr. Williams is with us online, but not here in person. Dr. Ali is one of my faculty. I'm really happy to have her. She's actually has a joint appointment with the Division of ID and the School of Public Health and Information Sciences. She originated from Trinidad and Tobago, but she's done her education here in Louisville, starting with Bellarmine and then moving to UofL, where she received her BA degree and then a master's in public health. And from there, she got her Ph.D. All at UofL in epidemiology. And then she did some postdoctoral fellowship, and that's when she started to work with us in the Division of Infectious Diseases. And so that work was in epidemiology and infectious diseases. So I would like to say nothing else except that she's done a remarkable job and published a lot since she's been with us since 2022, but with us a little bit before that, doing that fellowship, about 20 some papers. So please come talk to us about Streptococcus pneumoniae that we presented at IDSA this year. Sure.
All right. Okay, hi everyone. As Dr. Arnold said, my name is Sashura Ali, and today we're going to talk about serotyping of Streptococcus pneumoniae and clinical outcomes among hospitalized patients in Louisville, Kentucky. This is a preliminary study that we're doing right now, and we presented it at IDSA a couple weeks ago. So the outline for this presentation, I'm going to go over a little bit of background about what is community-acquired pneumonia, the burden of community-acquired pneumonia, focusing on pneumococcal pneumonia, a little bit about the epidemiological trends, shifts, vaccine timeline, specifically pneumococcal vaccine. We'll talk about the rationale to doing this study. We'll get into methods, study design, laboratory methods, results, discussion focusing on the epidemiological perspective and the clinical relevance, future directions, conclusion, and then we'll have a short Q&A. All right, so we have three objectives for today's talk. The first one is to describe the epidemiology and clinical burden of pneumococcal pneumonia. Next, recognize evolving pneumococcal serotype patterns, vaccine shifts, and resistant trends, and apply that knowledge to guide vaccination and antimicrobial stewardship. And then third, we have is to interpret the serotype-specific clinical outcomes from hospitalized patients in Louisville and evaluate the implications to results. So to get started, what is CAP? CAP stands for community-acquired pneumonia. It is an acute infection in the pulmonary parenchyma outside the hospitals. You have things like hospital-acquired pneumonia, ventilator-acquired pneumonia, but we're looking at CAP. So community-acquired pneumonia infection outside the hospital. It is a leading cause of mortality and morbidity worldwide, specifically among kids younger than 5 and the elderly over 65. A recent study published this year by Vanderbilt showed that the annual incidence is around 340 adults per 100,000. So every year, out of 100,000 people, 340 get hospitalized with community-acquired pneumonia. The CDC reported in 2023 that over 41,000 people die every year from pneumonia. And looking at readmission rates, because that is a hot topic with pneumonia, we see that 9% of people who are hospitalized with pneumonia are re-hospitalized with a new episode during that same year. Okay, what are some risk factors that predispose someone to getting hospitalized with pneumonia or even having poor outcomes with pneumonia? We see things like older age, chronic comorbidities such as COPD, heart disease, renal disease. We have other viral respiratory infections, impaired airway protection. If you have any sort of immunocompromising condition, that would obviously put you at risk. And other lifestyle factors like smoking, alcohol use, and even living in like nursing homes, so crowded areas where infection can spread, put you at risk. So getting into pneumococcal pneumonia, which, looking at Streptococcus pneumonia, that is a bacteria. It is a gram-positive bacteria and it is the most common bacterial cause of pneumonia. Okay, studies have shown that a lot of adults carry pneumococcal Streptococcus pneumonia in our nasopharyngeus. About 5 to 10% of the adult population, the healthy adult population, carry that bacteria in their nasopharyngeal. What we see usually with Streptococcus pneumonia is we have a non-invasive pneumococcal. Okay, so the bacteria is localized to the lungs. That again is non-invasive. That is a more common form of this bacteria. However, when the bacteria starts to invade other organs or other sites, for example, the blood, the brain, we have now invasive pneumococcal disease. Okay, and so for example, when the bacteria gets into your blood, you can have a pneumonia with bacteremia. That accounts for about 71% of all invasive IPDs. If that bacteria gets in your blood without a pneumonia, then that is pneumococcal bacteria, and that accounts for 14% of all IPDs. And then lastly, if that bacteria gets into your cerebrospinal fluid, then you can get potentially pneumococcal meningitis, which accounts for about 7% of all IPDs. And of course, as we see with these invasive diseases, there's a high case fatality rate as well. So looking specifically at pneumococcal pneumonia, the non-invasive form, we see that pneumococcal pneumonia accounts for 10 to 30% of all CAP cases in the US. It leads to about over 150,000 annual hospitalization, and its case fatality is around 5 to 7. It is higher among older patients, elderly patients, patients with comorbidities, specifically immunocompromising conditions. So I mentioned that recent study that looked at annual incidence, and so that study was done at Vanderbilt. It is called the PNEUMO program, pneumococcal pneumonia epidemiology. It's an active, ongoing epidemiological surveillance study looking at hospitalized CAP. And so they documented cases from 2018 to 2022. And what they found for all-cause mortality, as I mentioned, all-cause CAP, was that there was a 340 per 100,000. They also specifically looked at the incidence for pneumococcal CAP, and they found that throughout the 4 years, the annual incidence was 43 patients per 100,000. And then they went even more specific and looked at hospitalizations that were specifically had a serotype that was covered under the PCV21, which is a pneumococcal conjugate vaccine that recently got released. And that was about 30 patients per 100,000. As you can see, the bars represent different age groups. And as we've talked about, we're seeing an increased incidence with age as well. Okay, so as an epidemiologist, I have to talk about surveillance because that is a cornerstone of public health. We have to monitor and track, all diseases, all health-related states. So I'm going to talk about how can we surveil and monitor pneumococcal pneumonia. Well, there's many different organizations, systems. 2 specifically is under the CDC, or 3 actually. The first 2 are the main ones. We have the active bacterial core surveillance, the ABC surveillance. That is under the CDC's epidemic infection program. It is a population-based laboratory confirmed IPD surveillance. And so it's the gold standard. They use it to monitor vaccine effectiveness, serotype trends. I think it covers around 35 million people. It goes over about 8 different states. And so that again is active surveillance. They actually send people out to collect data on the cases. The other one is the National Notifiable Disease Surveillance System. I'm sure you guys heard of this before. So if you're doctors, you have to probably send in those reports. But this is a passive surveillance system where healthcare professionals have to fill out reports about notifiable or reportable diseases. Okay, there's about 120 nationally notifiable disease, and there's mostly infectious disease, some non-infectious. But again, we use this to monitor trends over time. There's about 3,000 health departments that send information to this surveillance system. Another way we can surveil for pneumococcal pneumonia is through laboratory-based surveillance. So the CDC reference labs, state laboratories, local laboratories, they can all perform different serotyping, antimicrobial susceptibility, and again, share that on a national level. We also have other surveys and systems like the National Immunization Survey or the Immunization Information System. They all track pneumococcal vaccination coverage and uptake, so they support, vaccine effectiveness and guidance updates. Another CDC system or network is the Antimicrobial Resistance Lab Network. This is a lab that monitors penicillin non-susceptible and multi-drug resistant pneumococci. They have 7 high-capacity testing reference labs, a pretty large national tuberculosis center, and they have different labs across the 50 states. And then lastly, we have places like hospitals and clinics that do their own blood culture surveillance. They have their electronic health record, or they have hospital cohorts, right? Research cohorts that they can study, like what we do here, or what Vanderbilt did. And so together with these research cohorts and these national systems, we can detect emergent trends of pneumococcal pneumonia. So speaking about trends, let's look at some epidemiological trends over the years. So really, looking at post-vaccine era, 2000 was when they released the PCV, which again, I'll go over the vaccine timeline in a second, but PCV conjugate vaccine 7 was recommended for children, and we see here that led to a very sharp decline in IPD rates. So as you can see the red line here, which covers PCV7 serotypes, we had a very sharp decline, which was great because as the kids got vaccinated, we saw that it increased herd immunity for adults. So the adults was then protected. So we saw now that adults was also protected, even adults who were not vaccinated, because that's what herd immunity does. It protects those who are not vaccinated, and even adults who are 50 and older. Okay, so we see here again, huge drops after PCV7, pretty stable after more higher valencies. We did see a major decline here with the COVID pandemic, and there's some theories about because of social distancing, mask wearing, maybe other concurrent viruses, things like that. We saw a major decline there, but because those measures are now lifted, people are not social distancing, people are going out, we're seeing a rebound in these serotypes now. So looking at, some epidemiological shifts, what are some things that can play a role in the shifting epidemiology? Well, like I said, a lot of these vaccine-targeted serotypes, the PCV7, PCV13, now we have 15, 20, 21, right? Specifically, those serotypes that are targeted by the vaccine are declining, but unfortunately, we're seeing other serotypes now rising, okay? And so one study found that there was a significant increase in serotype 3 just among hospitalized patients between 2013 and 2023. Like I mentioned, COVID-19 had a huge role to play. We saw that sharp decline in IPD rates. But again, as I mentioned, as the measures were lifted and people were going back to their usual exposures, we're seeing rates rebound now, increased incidence. And now, like I said, we have these new vaccines, hopefully some good shifting, where we have higher valencies like 15, 20, and 21 to cover more serotypes and hopefully address these non-vaccine serotypes. So all in all, with the combined effects of the COVID-19, these new serotypes that are emerging, these new vaccines, it's crucial for us in epidemiology and in the clinical world to monitor these trends and look and see the impact of these changes. Another big factor we need to look at is antibiotic resistance. So several of these non-vaccine pneumococcal serotypes have been showing notable antibiotic resistance. Specifically, it's been documented that a rise in penicillin non-susceptible and macrolide resistant strands, both in pediatric and adult populations. And so what they've alluded that to is most likely these post-COVID-19 shifts. They're thinking it could be disruptions in the healthcare utilization, maybe increased use in antibiotics prescribing, maybe changes in the respiratory pathogens. All that is putting selective pressure on, Streptococcus pneumoniae to sort of expand and create more resistant strands. And so speaking about resistance, this is data from ABC, the active bacteria core surveillance, the CDC. And we see here that they're showing you trends over time, the resistance for different bacteria, to different antibiotics. And we're seeing here that the biggest increase is macrolide resistance. Okay, we're seeing that now it affects about 30% of isolates. Most important to look at here is that a lot of these trends in the antibiotic resistance probably reflects the serotype replacement. Okay, so what we're seeing is that these serotypes have expanded after we introduce vaccinations. Those are the ones that are usually more often resistant. Okay, so that is a very important trend to take into account when we're looking at surveillance and antibiotic stewardship and higher valency vaccines. Okay, here's a nice little timeline just to give you up to date with the pneumococcal vaccination. We first started trying to make a vaccine in 1911. We had penicillin in the 1940s, which was great, but people were still dying from infection. So we're like, okay, we need a vaccine. And so the first pneumococcal vaccine was licensed in 1977. Then in 1983, we had, you probably heard of the 23-valent polysaccharide vaccine. That's a vaccine that has, the polysaccharides, the sugars in it. It's still used today, but the major limitation was that it was not effective in infants. However, in 2020, as you showed, we had the first conjugate vaccine. This vaccine has a sugar molecule attached to a protein, which elicit a stronger, longer-lasting immune response. So it was great and effective for young children. That's where we saw that major decline in IPD rates. Now we have, PCV13. We have all these other ones, PCV15, 20, and 21. And lucky for us, the ACIP recommendations just included a PCV21 for 50 years and over. Okay, so a nice little trajectory of vaccine evolution. And looking at vaccine uptake, so this was a retrospective study done using healthcare claims data for a population of about 6.8 million people, and they evaluated pneumococcal vaccine uptake. And what they found was that after those recommendations in 2022, when they came up with those recommendations about PCV20, fewer than 1 in 7 adults received any vaccination. About less than 1 in 10 received specifically PCV20, and fewer than 1 in 500 received a PCV15. So again, not where we would like to be. Looking at Kentucky, this was the latest that I can find in 2024. This map is by stratified by counties here, and this shows us the percent immunized with at least 1 dose of pneumococcal vaccination. So we see here we are, Jefferson County, about 55% has at least 1 dose. That's better than 2023, which was 49, but a drop from 2022. The national average I checked in 2023, I believe, was about 65%. So we're still pretty low compared to the national average. The highest county was Grant County, this one up here, with 72 or 70%. The lowest, I remember this, was Taylor. I think it's this one. Taylor County. It was at 32% was the vaccination uptake, so pretty low. All right, so moving into serotypes real quickly, because that's what we're talking about, vaccines, the different serotypes they cover. So if you didn't know, the capsular polysaccharide, which is the sugar capsule around the bacteria that makes it more virulent, is what also determines the serotype. Okay, so serotyping pneumococcal pneumonia is essential to monitor serotype dynamics, vaccine impact, emerging strains, all these different things. More than 100 serotypes have been identified since 2020, but only about 20 to 25 are accountable for 90% of all IPDs. Okay, so a very small amount is responsible for 90% of invasive pneumococcal disease cases. Some of these include serotype 3, 4, 6B, 9B, so on. 19A has been well researched to be a very highly virulent strand and multi-drug resistant. So we need to look out for that one. And this research project that we did, we focused on comparing 2021, because that's the most recent ones. And so you can see here in this table that PCV20, you can see, and 2021, they cover 10 similar serotypes. PCV20 covers 10 unique serotypes on its own, and PCV21 has 11 additional unique serotypes, so a little bit more. The paper that I pulled this from actually had information about some ongoing trials. So there's actually there's 4 documented ongoing clinical trials. I thought was interesting to see what they potentially might cover. And let's hope they're effective and make it to the market. Okay, last graph here, looking at in rates of IPD by serotype. So we're seeing how it changed over time by, again, vaccine serotype groups. And we're seeing at each major vaccination introduction, so in 2000 we had PCV7, 2010 we had PCV13. So at every major vaccination introduction, we're seeing a step down in disease. That's great because that reflects herd immunity. However, we're seeing those non-vaccine serotypes begin to rise. Okay, that's the classic pattern of serotype replacement. As we give a vaccine and it covers those serotypes, we see non-vaccine serotypes begin to rise. Okay, and again, we see this drop with COVID-19. So overall, again, the remaining burden of disease that's now, that we're seeing as it rises up is probably hopefully going to be covered by these newer vaccines. But again, we need to highlight the importance of ongoing surveillance and vaccine uptake strategies. So in summary, despite having a pretty strong and positive, pediatric immunization program, IPD still remains a very serious and ongoing risk, especially for adults and elderly population. A lot of studies have shown, and the ABC data have shown, that the risk of pneumococcal pneumonia increases with older age. It can get up to 2 times the risk for healthy adults around the age 50 to 64. That's compared to 18 to 49. And the risk is 4 times for adults over 65. And that's for, again, the risk of pneumococcal pneumonia. The risk of IPD is 4 times for those older than 50. And the risk of death from IPD is 6 times, again, compared to those 18 to 49. So, again, a huge public health problem we need to look at. And so looking at the rationale behind this project, we have all this serotype replacement going on. We have these emergence of non-vaccine serotypes. We see shift in virulence patterns that may impact disease severity, may impact hospitalization burden. And obviously, we're seeing it does impact antimicrobial resistance. So in the context of these newer vaccines, 2021, we're hoping to look for some sort of association between serotype coverage and severity of disease, because we haven't found a lot of articles exploring that, or they're very limited. And so the aim of this project was to describe currently the serotype distribution in Louisville, Kentucky, in hospitalized patients, and then next to compare clinical outcomes across PCV20 vaccine and PCV21 vaccine. Okay. So how did we do that? Well, this was a retrospective analysis of patients 18 years and over hospitalized with a confirmed S pneumonia. They were hospitalized from July 2021 to November 2024 at 3 different Louisville hospitals. We collected data from the EMR or EHR. The outcomes that we examined was time to clinical stability, which include the basic cough improving, afebrile for at least 8 hours, white blood count normal or improving, and oral intake and absorption. Then we had organ failure, which was either use of vasopressors, invasive mechanical ventilation, non-invasive mechanical ventilation, and renal failure or dialysis. Bacteremia, which was noted by the physician, and in-hospital mortality. We used the descriptive statistics and significant tests like the Man-Whitney U test, which compares medians, and then the chi-square and Fisher test, which compares frequencies. This was all done with our studio. To confirm that we had an pneumoniae isolate and to get the serotype, our amazing lab, the University of Louisville Infectious Disease Laboratory, it is a university-based CLIA certified lab. It's a high complexity reference lab. I'm going to give them their props. They are the ones that did this. They isolated the serotypes. They used I hope I'm saying this right, Quellen method. I read that it's the German word is Quellen, which means to swell. I could be saying that wrong too, because I don't know German. But anyway, what they do is they apply this bacterial solution that also has anti-serum in it, and under a microscope, the capsule, that polysaccharide, will swell, and you're able to identify if it's pneumoniae and also some particular serogroups. Thank you. Exactly. So that's what we use to identify if there was an pneumoniae and also the serogroups. So here's our results. We were able to enroll at that time 191 patients with confirmed pneumoniae. Here's just some characteristics of our population. We had a median age of around 50 years old. About 60% were white. There's some 26% of diabetes. Here's the outcomes, just the frequency. So the average time clinical stability was 5 days. 71% had organ failure. 26% bacteremia, and 15% of the patients died in the hospital. What's the interesting part is that what we found with the serotype, so 47% of our patients had a serotype covered by PCV20, while 70% had a serotype covered by PCV21. Okay? Here is the distribution. Again, these are 191 patients in Louisville, Kentucky. And so we're seeing that the most common strands, so in black here, we have the serotypes that are covered by both PCV20 and PCV21. In red, we have just the unique serotypes covered by PCV21. Blue, unique serotypes covered by PCV20. And the box is a serotype covered by neither. And so we can see the most common serotype is 3, which I mentioned that in my literature review. But among the top 10 serotypes that we found, 4 of them were uniquely covered by PCV21. Okay, and so for some preliminary analysis, we made 2 comparisons. So first of all, we did not have anyone that actually got vaccinated specifically with PCV21 vaccine. So this first comparison is looking at everyone that's infected with a PCV20 serotype. And we compared those who were vaccinated to those who were not vaccinated. So everyone here was infected with a PCV20 serotype. We're comparing to see if vaccination made a difference. And what we found is that there's no significant differences. The outcomes were similar. P-values were all greater than 0.05. Next, what we did is we compared those who are, so among those who are unvaccinated, we look for those who have a unique PCV20 versus those who have a unique PCV21 serotype. Okay, and so 9 people had a unique PCV20 that was unvaccinated. 75 persons had a unique PCV21 serotype that was unvaccinated. So we're trying to level up the playing field by looking at both unvaccinated, but seeing if the serotypes made a difference. And so again, the outcomes were pretty similar. There was a marginal significance with length of stay, maybe showing that, if you're infected with a unique PCV20 serotype, you might stay in the hospital longer. But again, marginal significance, not significant for an epidemiologist. Okay, so what does this all mean? Well, let's look at the epidemiological relevance, the importance. Well, we're seeing here, as I mentioned throughout the talk, that serotype replacement is evident, okay? We're seeing that there is more infections from PCV20 unique serotypes than there are PCV21, reinforcing the need for ongoing molecular surveillance. Like I said, among those 10 most frequent serotypes, we're seeing that the coverage between 20 and 21 was similar, possibly suggesting that, they're not dominant yet in these severe cases. So we should continue monitoring trends. Lastly, again, from an epidemiological standpoint, this study just again further solidified that we need to be pushing for vaccine recommendations on a local and state level. And again, if we can potentially link hospital data with registry data to really monitor vaccine effectiveness, especially when PCV21 starts to increase. On a clinical level, we're seeing that the outcomes in the hospital, again, were not different across those who are vaccinated and unvaccinated within that specific PCV20 group. So maybe these unvaccinated individuals may be trending towards a greater severity if you look at some of those percentages. But again, it may just suggest incomplete protection, but maybe meaningful. Length of stay, as I showed, may hint to some potential clinical benefits, but we may need a larger sample size to really get that, significant value. As far as the outcomes go, maybe the disease burden is driven more by host factors and comorbidities, not necessarily vaccination. And then lastly, hopefully, we want to obviously tie in public health and healthcare. So coordinated clinician and public health efforts to increase vaccine uptake and integrate, immunization status with risk assessment if we find out that it is relevant. So future directions, like I said, this is an ongoing study, so we'd like to expand this cohort, increase the sample size, go across different years, look for trends, look for some serotypes, different things like that, possibly even link clinical data with the Kentucky immunization record, try to measure vaccine effectiveness, possibly even look at, partnering with different labs, maybe do virulence gene profiling, maybe try to differentiate between whether if it's host-driven factors or serotype-specific pathogenicity. And then it would be great if we can have some sort of real-time data visualization tools or reporting tools. So building epidemiological dashboards to support healthcare systems, by monitoring serotype circulation, vaccine coverage, and all these different things. So tying together public health and healthcare to raise vaccine coverage and monitor clinical outcomes. So in conclusion, S. pneumoniae, pneumococcal pneumonia, remains a major cause of community-acquired pneumonia in adults. These newer vaccines, yes, they do broader coverage because they are higher valencies, but so far the outcomes are comparable, we're seeing with this small data set. And just to further solidify this point, epidemiological surveillance is essential to help us guide policy and resource allocation. Because if we don't know what serotypes are out there, we cannot, again, recommend the right vaccines or make the right vaccines. So here are my references.
Okay, we actually have some
Time
for your questions.
Expected that. Yeah.
That's good.
Okay.
Why don't you ask if Dr. Williams is online and if he has a question before I ask one? I want to defer to him since he's the chair.
Okay. Does anyone online have any questions, Dr. Williams?
Okay, maybe not. We'll give him time to unmute. So one of the benefits of this forum is that people from other disciplines in the Department of Medicine are here. And so I know there were some limitations with the Coelum reaction that you had because the serotypes is sometimes it wouldn't be for just one. Maybe like it would check, and I don't have this memorized, but for example, 31, but it would really be 31 or 33 or 35 or 37 or 42. We couldn't discern that, but you could with, I guess, another PCR additional, which gets more expensive. So I'm kind of wondering if somebody else in the Department of Medicine has a lab that also does this that we could use as well. And I don't know if they do or not. But that's one of the things that we would look for. And maybe it wouldn't be their laboratory we would need, but an instrument or something like that. So that's not so much a question for you, it's just a note to the audience. So I found it interesting that you said the first vaccine was in 1911, and I'm pretty sure they discovered serotypes in 1909. So that must be where they prompted the vaccine. So way back then, serotype 3 was probably also common. And one of the bad things about 3 is it's more severe than some of the other serotypes. And so every vaccine has serotype 3. I didn't look at those newer ones, but I would presume they also cover 3. So
Yeah.
yeah, I don't know if you have a comment about that far back in the history or not. Does somebody else have a question?
Yeah, for serogroup 3 in the lab, when we see like serogroup 3, we see by visually it's so mucoid, everything else looks normal. Probably that mucoid nature is very hard to protect.
So you can tell with the naked eye.
Yeah, we can see the play. Oh, this is serogroup 3.
So
Okay.
that could be what's making it really virulent.
Yeah.
Yeah.
And
so pervasive.
Vaccine also failure for that. I'm not 100% sure because it's more mucoid. Even when the lab test when we do, it's not reactive.
Okay.
So we have to do PCR.
I see.
Yeah.
Does somebody else have a question for Dr. Ali?
I have a question.
Yes.
So maybe not only for you, but maybe for the other faculty here, ID. So I'm a rheumatologist, so we use different biologic for our diseases that goes from anti-tuberculosis factor, the I-17 inhibitor, I-6 inhibitors, so all those type of immune system inhibitors. And yeah, we do recommend to give vaccination prior to our immunosuppression, but that sometimes doesn't happen. There is always discussion about timing of such vaccine with our immunosuppression treatment. So that's maybe the first type of my question, or first part of my question. Any advice on timing? Patient did not, I mean, ideally it should be prior to treatment, but sometimes that doesn't happen. And then actually sometimes patients come to us like from our infusion center. So patients there, when I get some sort of infusion that suppresses immune system, could be rituximab, which is anti-CD20, and then you will get vaccination at the same time. If that's okay to do, not okay to do. So maybe that's beyond your, but maybe Dr.
Yeah, okay. I'm happy to answer that. So it takes about 2 weeks, to develop antibodies to whatever vaccine you get. So I don't know how far apart your injections are, but they're at varied times. Some of them are 6 months apart. So the very best time would be at least 2 weeks before the previous injection. Now, if you get injections every 2 weeks, that's not going to work, right? But ideally, not 2 days before, but 2 weeks before, or even a little bit more for the timing. And then for your infusion center, it's kind of difficult. But again, that timeline might hold some water for 2 weeks, at least 2 weeks before, or a little bit more. And some patients may dictate, like I have patients come to clinic and they have a couple no-shows in their chart, and I'm just like, you're here, you're getting a vaccine, so it's not ideally the pathophysiology that's guiding when I vaccinate them, but it's when their presence. And so it's also ideally, best to get a vaccine one at a time so you can develop your antibodies, but we double, triple them up just because it's inconvenient to come in so many times. And that's okay. But again, sometimes I get a patient and they get 5 vaccines because they're there that day. Dr. Doster, do you have any other comments?
The problem is the meds are all variable, right? Variable in the amount of risk you have, how long they act. So I mean, I think if there's question about a specific one, that's something we can kind of look up and develop a strategy for. But to say a strategy for all of them, I think is difficult. I mean, certainly if you have somebody you're going to start, getting them vaccinated before they start is preferable, but that's not always an option.
Yes, yeah.
So after developing immunity, before treating any anti immune suppressor.
I mean, yeah, biologic.
Do you think when they treat with immunosuppressor, all this antibody developed in the body will go down against the
Yes.
vaccine?
Right. That's why it's best to do it before you get the vaccine in the first place. So your immune system can have a response because it'll be muted after you have that biologic.
But the body still have the vaccine effect.
Yeah, to some degree, but not as good as when your
Um,
immune system was higher. Exactly. Somebody else have a question? Yes, sir.
So at my last annual physical exam, I was offered for the first time the pneumonia vaccine, and I can see now why that was, and I accepted it. I'm discouraged to see though that my chances of showing up in a hospital in Louisville are no better or worse than someone who didn't get the vaccine. So what hope
Yeah.
do you have?
Well,
in the
this is
future?
not the only study, fortunately, because this one only had almost 200 people in it. But if you look at the studies where there's thousands of people who are in their studies, this was just Louisville, then there definitely is a benefit. And actually, if you show the table, all of the outcomes trended better for every outcome. And if we had had more people in the study, it probably would have statistically been better for the people who got the vaccine. So the other thing that the vaccine does is maybe you do go on to get strep pneumonia, but you don't have the bacteremia that goes with it. So you get a case, but it's not as severe. So the vaccine can protect you from some of the more severe cases of it. So yeah,
Yeah,
have some confidence. It was a good
we
decision.
just need like more sample size, but yeah, a lot of the clinical trials and other bigger studies have shown that yes, they do make a difference as far as like invasive pneumococcal disease, reducing your risk.
All
But
right.
it's just, this is a preliminary analysis, very small sample
Yeah,
size.
it's there. Is your other slide with the
Yeah.
outcomes on it.
I don't have access to that, to change it.
What? Oh,
Oh, just press this?
Yeah.
Left
yeah.
arrow.
Alright.
Yeah.
Oh.
No. So,
Yeah,
this one,
back one.
Okay.
Cause this is comparing
Oh,
the
that was
outcomes.
great.
You see, they're all better on the left column than they are the middle columns. They're just,
Yeah.
if we had more people, probably there would have been a statistical.
Well, that is encouraging.
Yeah, it is. And there's
So-
other studies that can show that.
A second question, this is specifically the community acquired. Is there any overlap with serotypes with the hospital acquired pneumonia?
Oh, Streptococcus pneumonia doesn't usually cause a hospital acquired pneumonia. That's worse bugs like Pseudomonas and Klebsiella. And there is not a vaccine for those yet.